So this is module 2.5 on stroke. So our HPI, we have a 65-year-old male who presents with weakness and facial droop. Patient states the symptoms started 1 hour ago while he was working on his computer. Patient says his blood pressure has been high and trying to get into his doctor for months. Patient denies any headaches, nausea, or vomiting. Patient admits to difficulty walking and slurred speech. So it's important to kind of nail down a couple key components with an HPI. One being the onset, whether it was sudden, gradual, or unable to describe, or obtunded. Someone who comes in who has a high level stroke, who's not communicating, not verbal, not actually doing much for following commands. Current symptoms, whether they're worse, improved, no change, or resolved. Many times we see patients that come in with stroke symptoms that by the time that they actually reach the doors of the emergency room, their symptoms have drastically improved or resolved. So it's very important to note the current symptomatology in these patients. Also, are these symptoms constant or intermittent? So a couple key associations. When we have several things that keys us into very bad outcomes for patients or increases our level of concern. Several of these things are headaches and neck pain. A lot of the subarachnoid hemorrhages and bleeding strokes are associated with the headaches and the neck pain. If a patient has a seizure, that can indicate that there's increased pressure in the brain, so whether a mass or a bleed. Syncope or passing out, and vomiting. Vomiting is another symptom that when the patient's intracranial pressure goes up in their head, they actually triggers the vomiting reflex. So these key things, headache, neck pain, seizures, syncope, and vomiting, very, very bad symptoms to have with stroke symptoms. The other less concerning, vertigo, dysphagia, which is difficulty swallowing, dysarthria, which is slurred speech or difficulty speaking, and visual disturbances. So our physical exam, this patient's vital signs are 180/90, which is hypertensive. Always ask your physician whether they think that the patient's blood pressure is hypertensive or not, because different physicians have different takes on hypertension. 140/90 may not be considered hypertension to your doc. So just make sure you're always asking for your documenting if the patient's hypertensive. 100 is tachycardic, 16 respirations, 99% of room air, and afebrile. So our general exam, the patient's A&O times 3, alert, awake, oriented times 3, and no distress. HEENT, patient's pupils are 5 and reactive. Patient has a good gag reflex and a left facial droop. Chest is clear to auscultation, which means that the lungs are clear, there's no wheezing. Heart is tachycardic and there's no murmur. Abdomen is soft, non-tender, non-distended with good bowel sounds. Extremity exam, 1+ edema bilateral with no calf tenderness. And the very most important part of our physical exam, key to our chief complaint of stroke, is our neurological exam. So this would be a pretty comprehensive neurological exam when seeing a patient with your physician. So muscle strength is 5 out of 5 in the left arm and leg. Muscle strength is 4 out of 5 in the right arm and leg. Patient's able to raise their leg off of the cot on the left, but not able to on the right. Sensation is intact in the bilateral arms and legs. Patient's grip is weaker on the right. Patient has dysarthria, which is slurred speech. And patient's facial sensation is intact. So some very important documentation keys. Always, always, always document a complete neuro exam. It's not enough to just put sensations intact, motor strength 5 out of 5, and patient's A&O times 3. So always document, cranial nerves, grip strength, whether a patient has equal finger to nose or heel to shin, the cerebellar signs, symptoms. When your doctor is doing his neurological exam, just make sure that your neurological documentation is complete. Always document an NIH stroke scale, and your doctor will actually go through the scale and give you the number, and we'll touch on this a little bit later. Always document the inclusion and exclusion for TPA. So in different EMRs. It can be found under the Procedures tab. If you're going on the stroke template, it should be actually in the actual stroke template for inclusion exclusion, but it should be somewhere in the EHR where you can find inclusion exclusion. And always document TPA is given because or TPA is not given because. So you want to make sure that there's actually a clear documentation on why it was or was not given. Never state the symptoms started prior to arrival. You either want to document unknown or a documented time. For imaging, CT of the head must be documented in the event there is a bleed. If there's a bleed, this is an absolute contraindication for TPA, which we'll touch on TPA, which is the clot buster, like the liquid Drano, which clears out the vessels if there's any sort of blockage. And if someone's already having a bleed, stroke, that's a hemorrhagic stroke, TPA is obviously not the choice for treatment. So this is a little diagram kind of the different types of hemorrhages. There's an intracerebral hemorrhage, which is where you have blood inside the brain or the artery within the brain ruptures. And then we have the subarachnoid hemorrhage, where there's a ruptured aneurysm and the artery is on the surface of the brain. This is a CT image of an intracerebral bleed. So this is blood within the brain. So you can see that the white hyper acute area, that's blood on that CT. And there's also just kind of a cartoon diagram of where the bleed is. So this is a timeline that we use for TPA. Within 25 minutes, we want to get the patient's head CT done to document that there's not a bleed. Within 45 minutes, we want our lab results and our CAT scan report back. And then at 60 minutes, we want to be starting our TPA bolus. The earlier that we start TPA, the better the outcomes are with the patient. So time is very important. Just like with heart attacks, time is important for better results. So we have TPA. This is our liquid Drano or clot buster, and from symptom onset we have 3 hours to administer. So it's crucial that we document that the patient arrived at so-and-so time, patient was administered TPA at so-and-so time, and the symptom onset was at so-and-so time. So some patients, we also have additional criteria to extend that TPA period to 4.5 hours after onset, which your physician will let you know in particular cases where that would be important. So our NIH scale, we don't want to go too much into it, but we have our level of consciousness, and then we have basically our level of consciousness questions and commands. So we're asking, do they know where they are, who the president is? For the commands, if they can close their eyes, if they're able to squeeze my finger. You know, best gaze is essentially how their visual fields are. Facial palsy, motor in their arms and their legs. Limb ataxia is the finger to nose or the heel to shin, your cerebellar tests. Sensory exam, best language, which we'll go on to the next slide and I'll show you how that gets documented. Dysarthria, which is the slurred speech. And extinction, where we have them close their eyes and we're touching various parts of their body and they're actually able to localize where we're touching them. So this is the best speech. So this is the common pictures that we use. In the upper left corner, you see that the mom is washing dishes and the water's overflowing and the son is in the cookie jar and the stool's about to fall over and the daughter is reaching up for a cookie. In the upper right, there's just some objects. Sometimes we just point to our watch or our pen, but this shows the glove, key, chair, hammock. So there's different variations on if the patient is able to recognize and cognitively be aware of what's going on. Then we have a couple sentences starting, you know how, down to earth, and we're able to better figure out how their speech pattern is, if they have any broken speech or they're actually able to get every word and actually march out the entire sentence. So here's a documentation on a facial droop. So sometimes it's not, you can't see this when a patient is not actually smiling. So part of our exam is to have the patient show us their teeth or smile. And on this patient, you can see that he's documented a right facial droop. When he smiles, you can see the wrinkles on his forehead, where they actually looks equal all the way across, and there's a right facial droop. when a patient has a diagnosis of Bell's palsy, you will not see the wrinkles on the right side of the face. The facial droop will be on the right, and the forehead will actually won't be able to move as well. So the whole right side of the face is completely knocked out. Now there are variations of stroke, brainstem strokes, that actually can present like Bell's palsy. So Bell's palsy is typically caused by viruses and can resolve with some steroids and some antivirals. So again, a little bit beyond the scope of this lecture, but keep in mind that that's mainly what we're looking for when we're trying to delineate the facial droop or a Bell's palsy. So here's a couple things for IV TPA for acute ischemic stroke. Again, two types of stroke, ischemic or hemorrhagic. Ischemic is the blood clot where the flow and the oxygen is not reaching the brain, where we can use TPA. And then the hemorrhagic stroke, which is the bleeding stroke, where we do not use the TPA. So here are some of the exclusion criteria, one being rapidly improving or minor stroke symptoms. NIH scale is less than 4. It's important to note that if a patient's NIH scale is 1 and it's slurred speech, or 1 and it's the motor strength of their dominant hand, then that's not considered minor and they still may be a TPA candidate, because if they're not able to write the rest of their lives or their speech is disturbed, then an NIH of 1 is important to be treating with TPA. Another exclusion criteria is severe stroke symptoms. So if their NIH scale is off the charts at 25 or above, then TPA would be a dangerous or a more risky choice because of their high-grade stroke. Stroke or serious head trauma within 3 months, major surgeries within 14 days, history of bleed. So if they have any history of head bleed, they are completely excluded, because once you have a head bleed, then if you do give TPA, the chance of you having a rebleed is very high. So systolic pressures over 185 or diastolic over 110. And you are able to treat the blood pressures to get them below that range. However, as the last one states, if there's aggressive blood pressure treatment and continuous IV infusions of antihypertensives, that is going to be an exclusion. Okay, so for documentation, patient updates are a necessity. These patients are constantly, their clinical course is changing rapidly, minute to minute, hour by hour. So anytime your physician goes into a room, it's very important to document what was said, what was the family involvement in the neurology conversations, getting the neurologist on board. So I kind of gave a summary of a medical decision-making clinical summary, and it states Dr. Perkins assessed the patient at 10 a.m. Symptoms started at 9 a.m. Patient had an NIH score of 6. The head CT showed no bleed. Patient met all inclusion criteria and none of the exclusion criteria. TPA was ordered at 11 a.m. Dr. Perkins spoke with neurologist Dr. Brain at 11:15 a.m., who agreed with the assessment and TPA administration. Patient and family aware of the risks of TPA, including a 6% risk of a head bleed and 45% mortality from the bleed. Aware that 30% of patients that receive TPA will fully recover from stroke. So TPA was given at 11:45 a.m. and patient was transferred to the neuro ICU. So a couple important statistics that were in this slide is that when we give TPA, there is a risk of 6% chance of a head bleed. And of those head bleeds, 45% or almost half of those bleeds are fatal. So these are some of the statistics that I myself as a physician go over with patients, families, and patients before pushing that drug. And your physicians may do the same. Aware that 30% of patients who receive TPA will fully recover. So just by pushing the TPA, it's not 100% recovery if you're within the 3 hours or the 4.5 hours. So it's very important that the families and patients know that the risk of the head bleed is not just the only risk, but it's also that the risk that it may not work at all. So again, very important documentation keys with stroke. Time is very important. Documenting that CAT scan that it's negative. Another part is if the CAT scan is negative and we're not giving TPA, documenting the time that aspirin is given. So very important keys that need to line up, and it's just kind of got to read along like a story So we're able to get from point A to point B, and we're able to cover everything that needs to be covered in regards to a stroke patient, because it's a very acute, time sensitive patient, and there's a lot of times that need to be documented, and a lot of drugs, and a lot of conversations.